So, that being said, we have a wonderful, wonderful topic today. Myself included, started off learning about integrated care as a counseling trainee at the time. And, you know, it seemed to be 4 or 5 years ago, there just really wasn't a whole lot, or maybe even there was just starting to be more growing awareness of the role that master's level counselors have in integrated care and other master's level clinicians as well. So, that being said, we have a great topic today where we're going to focus on promoting the counseling profession in medicine. My background, just to give a little bit of understanding, I am a postdoctoral fellow at Community Health of Central Washington. Also, I graduated from a CACREP accredited counseling program, and I was part of a HRSA training grant in integrated behavioral health care. So that's kind of how my side of training fits into this. Tiffany, we're stoked, excited to have you here today to talk a little more about this topic. Before we dive into that, I would love if you could just give a brief rundown, a little bit of background on yourself.
Sure. Yeah, I'm excited to talk about this today. A little different than the background that Corey described. I also graduated from a K-CUP program. I've been working in the mental health field for roughly 17 years and learned about integrated care about, I would say about 4 or 5 years ago. And just kind of stumbled upon our FQHC here in Augusta, Georgia that was hiring and had become a little frustrated with some of the systems of care in the specialty mental health care setting. And when I learned about integrated care, I kind of fell in love with integrated care, came over from the dark side of specialty and into integrated care. And in true integrated care fashion, I'm sitting here in an exam room because I am working in integrated care now, but I'm also a doctoral student in a counselor education program through James Madison University and really want to contribute now to expanding just the access to integrated care trainings and education. And so that's where I'm at now. Yeah.
Perfect. Yeah, thank you for that, Tiffany.
Mhm.
So definitely the passion is there, right? And I think that's one of the big things that draws many of us to this field and just the wonderful things that we can do. So as we dive into the presentation, I do want to give a heads up that we do have the chat. I'm working to monitor that. So as part of this, if you have any questions, please feel free to pop them in the chat. I'll try to get to them as we go through. The other part I'll say with this is as we go through these slides, we bring up some topics for discussion. That being said, if something more pressing comes up or something of greater interest, we are open to further exploring that too. So with that being said, I'll go ahead and jump into the first slide here. And Tiffany, I'll let you talk a little bit about this.
Yeah, sure. So this will be our kind of agenda for the conversation, but of course, we'll be flexible in that as we move along. But we do want to start out with some introductions, and with the number of people we have, if you don't mind to use that chat feature, just to let us know who you are. I'm wondering how many counselors we have in the room. I'm wondering if there's other professions represented, social work, psychologists. Any medical staff. If you just let us know who you are, what discipline you represent, maybe your location, where are you at, and what is your connection to counseling and integrated care? What is your connection to this topic? Are you working or supervising or interested in involving more counselors? We'd love to know that. So if you don't mind to take just a moment and type that in the chat, we'd love to know who you are. So I'll pause for a moment. Like we're seeing several different professions
Mhm.
represented. So it's great that we're coming together to dialogue today.
Absolutely. And I definitely appreciate the different levels of development and training where people are at too. So it looks like we
Mhm.
have people from all different levels, whether still actively in training, in school, early career professional, even someone with a bit more years of experience under their belt. So that's awesome. I love the variability.
Yeah, great. So we're gonna have a great conversation.
Mhm.
Okay. Um, as people continue to share,
Mhm.
we'll look at the agenda here again. We'll align ourselves just with a few key points as far as the status of the counseling profession and integrated care, and feel free to chime in here as well. And then we'll move into our discussion points. But we just wanted to start off with aligning ourselves with those few key points before we discuss and then close out. And we can go to that next slide. So just a few things to align us, because we might have varied experiences represented in the room today. I know for myself, I didn't know what integrated care was several years ago. And so if you haven't heard of the different levels of integrated care, there is a hyperlink on these slides, and maybe we can get that in the chat. But the SAMHSA HRSA Center for Integrated Health Solutions has detailed out 6 levels of collaboration and integration. And so that's what we're talking about when we're talking about integrated care. So we just kind of want to align there because there are varied definitions out there. And again, like me, if you hadn't heard that word before, it's kind of a lot to explain. But I think this gives us kind of a framework on what we're talking about. So I won't go in detail on that, but that hyperlink is there. If it's something that's new to you, I think that's a great place to start to understand kind of what those levels of integration can look like. And then a couple of points to share more recently. So 2024 has been, it seems like a big year for our counseling profession, as we've seen a lot of advances. We've heard about the Counseling Compact. Likely, if you're in the counseling field, you've been hearing about that. We've heard about this Mental Health Access Improvement Act, and what I've tended to see coming out from our national organizations is more, that we're able to now register with Medicare. We're able to bill Medicare, right? That's kind of one of the big things we see. But one of the pieces of that Mental Health Access Improvement Act was also to change the definition of who's recognized as a behavioral health provider in our FQHC and that's federally qualified health center or our rural health center settings. That was beginning this year. So that's a big change in that prior to 2024, at least nationwide, it was determined that licensed clinical social workers and licensed psychologists were the recognized behavioral health providers. With this act, now we have added LMFTs and our LPCs. So that certainly makes a difference in terms of where we can work and how funding is, how those jobs are funded, and how we can bill insurance. So that was a big step in 2024, as well as if you know about CACREP Standards, if you've been in a CACREP program or you teach in a CACREP program, you know that's our Council for Accreditation of Counseling and Related Educational Programs. And we did recently have updated standards. So we went from the 2016 standards to the 2024 standards. And one of the things that stood out there is that integrated care and primary care are acknowledged as a part of the counseling continuum of care. And that was previously absent from the prior editions of those standards. So again, kind of two points there to align us in this conversation as we kind of move in to discussing. Okay.
All right.
Oh, go ahead.
Do you want me to read it, Tiffany, or would you like to?
You can go right ahead.
Okay. Yeah. So, really, as we kind of segue into this, and we definitely want a lot of participation from, you all, because again, you're here, you're taking time out of your busy day. We'd love to hear kind of thoughts, feedback, that sort of thing. So really the first kind of big discussion topic, what are the expanded opportunities for master's level counselors in integrated care? What are some of the benefits of including counselors in the integrated care workforce? And sometimes we can start off with some of our own thoughts on this and kind of see where it takes us. So I'm already seeing some activity in the chat. So thank you, Michelle, for chiming in. So first big one, increasing access to care. Collaborating with physicians and other providers. Thank you, Casey. Keeping site staff, that's a big one too, James. Yeah, that is a huge one as well. Filling the shortage of behavioral health providers in primary care and other medical settings. Thanks, Nick. Great training pathways, having staffing shortages, helping in rural settings. Absolutely. Increased diversity of workforce. Perfect. Thank you, Tara. Different perspectives. Yeah, allowing students to strengthen their treatment planning for various presenting concerns. Absolutely. Advanced client care. Absolutely. So some great things already listed.
Mhm.
Tiffany, where does your mind go with some of what's been shared already?
Yeah, I think definitely what stands out to me is our shortages. We think of I think you mentioned being a part of a HRSA training grant and some of our health professional shortage areas. We see that as a topic today, that there's more and more attention to, more and more funding to going to. And certainly we can be a part of that workforce to fill some of those gaps. Our rural areas, we know, tend to have a lot of need as far as access to care. So certainly, and I think I saw increased diversity of the workforce, additional, perspectives. And I'm seeing pop up our traditional foundations in wellness and the profession. We definitely we give, I think, a unique skill set to the field in that we come very much from a humanistic perspective. We tend to as counselors, and so we add kind of a different way of viewing healthcare from a whole health perspective as well. So, yeah.
Yeah, absolutely. I mean, so much of what you said like really sticks out to me, Tiffany. And even looking through the chat here, you know, counselor preparation programs. I mean, at least when I was, going back through this, there was maybe three or four in the nation at the time that were doing this kind of preparation work. And this was about, gosh, it's been about 4 years at this point. And it's been really cool to see how much this has grown, and just even looking at the chat here, it's really cool to see people chiming in too about the ripples that this training has on the medical system, right? And as you're saying too, with like underserved areas, especially, which, those don't necessarily have to be rural, these can be areas that are urban as well, that there's just such a huge provider shortage. It's really creating the opportunity for counselors, which we have a larger workforce in some respects than other disciplines, to get in there and do some really good work and be part of really this greater emphasis of person-centered, whole patient-centered care. Um, so like I definitely, what you're saying resonates with me, and it seems like it's resonating a lot with people as well.
Mhm, mhm. Yeah, I'm even thinking of the folks I saw in clinic. Like I said, I'm here in clinic,
Mhm.
and I'm also an educator as well, but I think of the people I saw in clinic may never step foot in a traditional mental health setting. Those referrals that drop through the cracks, and there's such an opportunity for providing mental health support, for behavioral health support, but also that early prevention. When kids are coming in with stomach aches and we're able to talk about the potential of anxiety, when maybe that would be overlooked in a traditional healthcare setting, we can add that dynamic to the clinic areas and the health um, to the healthcare workforce.
Absolutely. I mean, Daniel had posted a great comment on here too, bridging the gap between medical providers and mental health professionals, highlighting underlying mental health issues, kind of like what you're saying, Tiffany,
Mhm.
in terms of, those stomach complaints, how that might be factored into something like anxiety, and also just the behavioral approaches and the behavioral impact we can have with treating chronic disease management, just some really big things there. And there was a study at this point, I want to say it was like 2020 by Kanzler and Obide, that actually they tracked the follow-up rates if a person was given a referral to specialty mental health and primary care. And it's less than a fifth of the patients follow up on said referrals. And even they looked at a sample of individuals in the military, and the military sample actually was pretty low as well, when those services can be readily available to many of those armed service members as well. So yeah, definitely what you're saying, it resonates a lot. I'm curious, Tiffany, given that we have, so many different disciplines here,
Mhm.
and we've talked a couple of the things that you've shared about the benefits of counselors. I'm curious to see maybe some other areas where your mind goes. in terms of, the unique aspect of counselor training, right? Like, it has a different flavor than other disciplines. What are some things that you've maybe noticed as part of your training, your development yourself as an educator throughout this process?
Yeah, I think going back to kind of that foundation in the humanist perspective that we're really taught in our counseling programs, or at least I was taught in my counseling program, to really sit with our clients who are in front of us, our patients who are in front of us, and really get to what is important to them. And sometimes in our medical settings, we're trying to do a 15-minute visit, and that's hard. That's hard to do for a medical provider to go in and find out what's important to their patient. And so I think we bring that perspective, and we can do that. We're trained to do that pretty quickly, to really be attuned to clients, to look for those nonverbals, to all those basic counseling skills that are really ingrained in us. We just bring that connection and that ability to find out what's important, and how we can help facilitate change or advocate, or whatever the need may be. And I think that is unique to counseling. I think other disciplines bring wonderful things to the table, but in counseling, that true connection, that just person to person connection can be so valuable. When we are talking about diabetes care and someone really struggling with their A1C, what's really at the root of that? How can we connect?
Yeah, definitely. Yes, I mean, so much of that stands out with my prior experience too. That heavy humanistic emphasis. And I mean, I think most of us on this call can probably relate. There's been moments, whether you yourself have experienced it or a patient, where medicine has not been a humanistic practice,
Mhm.
right? Like, we've had many of the patients I currently work with, half the time I'm doing some damage control and trying to figure out where are we at so that way they can continue to get the best possible medical care they can. And I definitely think too, like with counseling, the heavy humanistic emphasis is really a beautiful thing. And my mind kind of goes in the direction, because I know we have a mix of folks on the call here too. LMFTs, their systemic perspectives, I think are so beautiful and like so eloquent. LCSWs, like understanding the systems people live within, having that greater understanding of that's powerful. Even folks like myself who have also gotten some training as like a psychologist, we get a lot of that similar experience, and it's some of the depth understanding of how patients may benefit from additional services like assessment, evaluation, things like that. It's nice just because, if anything, it's really helping us provide such a deeper level of patient care, human care, than they would get without the presence of behavioral health providers. So absolutely beautiful. Okay. I'll go ahead and segue us to the next question. So what are the potential barriers to the increased integration of master's level counselors? Mm, Nick, addressing one of the big elephants in the room, lack of training.
Yeah,
Absolutely.
yeah, yeah. I'm thinking, as people respond in the chat, I'm thinking I'm
Mhm.
teaching the introduction to mental health counseling course for the summer, and in the book, integrated care is not there. It's not listed as one of the potential agencies or types of places that we can work. So,
Absolutely. Yeah, and a couple other things pop up here. Stigma, not being seen as level on the playing field, provider clinic resistance, acceptance of physicians and psychologist colleagues, power imbalances, triggers a reassessment of prospective payment rate for FQHC. That is definitely a big one. Discomfort increasing the bio and biopsychosocial conceptualization and treatment planning,
mhm,
leadership decision making, rigidity of choices and counseling programs. Yeah, like quite a number of systemic issues,
mhm,
right? And, just to kind of address some of these, I mean, I can think of just my experience as being part of this first grant that I was part of. I think I was within cohort number 3, and I trained with the second cohort. And it was interesting because exactly what was being mentioned on there is these same challenges, right? I mean, to a T, because we had some students who were currently doing their internship, some that were getting ready to. And, this really, there's a lot of question marks about this. And even from people that taught in the program, they're like, I don't really understand what this is and why
Mhm.
students are getting trained into this. Is this counseling? Right. And, it was an interesting crossroads to navigate as someone who became very passionate about the work and me having to explain that to somebody. It's like, well, this is doing a lot of the wonderful stuff you do, just in a different kind of setting and structure. So,
Yeah, certainly branching out of that, the 50-hour session in a room with a sofa and a couple plants, kind of branching out of that as the ideal setting.
yeah,
Um,
yeah.
yeah.
Absolutely. And one of the things that a couple of people had mentioned here too is just really the system that they operate within, really increasing that buy-in, maybe dealing with a quote unquote resistant provider, because we all have had experiences with, I'm sure, some our medical colleagues who maybe don't entirely understand what we do, maybe have some thoughts about how this contributes to patient care. But also things like at the organizational level. So Tiffany, given the setting you're in, what are some of the things you've maybe noticed at the organizational level for you?
Yeah, I am. I know one thing. I know I'm really fortunate. I'm in a clinic that it really embraces integration, really desires it, and desires to do better. But that's my clinic. We have several clinics in our organization. Not every clinic is that way. There are some kind of more traditional, uh, I guess, views as far as the medical setting. Maybe the medical provider is really desiring to see the patient first, and then to really oversee that care versus having that team-based care approach, being okay with me running in the room ahead of them because I see something in the chart that might be something I could contribute to. There is some maybe not pushback, but just discomfort because that's new,
Mhm.
that's different for the medical providers. Sometimes the assumption being if someone is in emotional distress, that's the reason that the behavioral health provider comes in. But if they're not in emotional distress, there shouldn't be a reason for them to receive any sort of behavioral health support.
Right.
So kind of that nuance of there's so much more that we can do beyond just a presentation of emotional distress. So I think that's organizationally some of the mindset shift that we've had to make here. Um, and also things like for us in Georgia, there's some barriers to some of the coding and the billing and the how to document because it more aligns, some of those requirements align more with specialty mental health, and we just don't have the EMR set up or the time to do lengthy treatment plans and things of that nature. So that's another kind of organizational or systemic factor at play for us that sometimes is a barrier to integration, trying to keep up balanced paperwork and the clinical practice. So those are some things that stand out for me in my particular organization.
Absolutely. And, the organizational component is definitely something I see a lot of ambiguity with, not just in this setting, but in others as well. Like, what exactly is it you do? How does this differ from specialty mental health? How does this differ from co-located care, which the framework you had shared earlier, I think is a great one. And we'll probably send these slides out as well. So yeah, I think that's, without a clear definition, what are we doing? Right. Because then it's like, nobody's quite sure how that breaks down, and it can be frustrating when you know you're somebody who is trying to have to explain to an organization, HR, like, this is kind of how this works, this is my role here, this is different from what you've been doing for 15 plus years. I think there's a lot of challenges with that, and something that I've also seen too here is the counselor preparation side of things. And as you mentioned, as someone who's an educator, um, and some of the probably the challenges with that while CACREP is recognizing this is a potential competency, this is a vital role,
Mhm.
it may still feel like programs are lagging behind a little bit.
Mhm. Yes. definitely see that. There's some of that resistance of, is that really, I think somebody said it, you might have said it earlier, is that really counseling?
Mhm.
If you're going into a room, and even in my doctoral program, I'll be transparent, there was some question of, is the medical setting, is it influencing you too much where you're not staying in your counselor role? And I said, well, no. But there's those kind of that little bit of pushback or resistance still in understanding.
Yeah. Well, and I'm curious, Tiffany, given your experience and that, as you mentioned, teaching that sort of thing, do you find yourself maybe kind of at a grassroots level advocating more for it, like with trainees, having more conversations with faculty members? What do you find?
Yeah. Absolutely. In my role now, I'm adjunct now. I'll be moving into a full-time educator role soon. But I absolutely take time to introduce students to integrated care. I make them aware of the benefits of getting training in integrated care, working some of the student loan repayment programs, letting them see that LPC is listed there. So it's real, and there's advocacy shifting toward that. And I think that makes it real to them when they see those repayment programs and training programs and say, oh, I'm listed there. Counselors are listed there, along with the social workers and the psychologists as well. Um, and I try to introduce it as a growing area that counselors are working in, so that they know it's there, even if it's not in those textbooks. And I certainly educate faculty about it. When we talk about it, they say, does that influence you? Are you practicing more under a medical model? And I share about that. And I share, actually, no, I'm influencing the medical community. I'm able to help providers and medical providers see things differently. And I think that that kind of shift in thinking, that it's not a medical model versus versus humanistic model here. It's, we're all working together to influence one another. And I think when they start to understand that, that can bring some understanding in those one-off conversations. So yes, very much grassroots,
Mm,
as I shift more toward research. But there's definitely day-to-day advocacy.
yeah, absolutely. Yeah, and I mean, a couple of the comments that kind of definitely feed into that too is the having more qualified supervisors in these kind of settings for LPC, LMFT interns. Also, just recruiting new talent, to programs can be tough when maybe there's some barriers. People don't really understand the integrated care aspect as well. Yeah, the PSLF is a nice thing. Is a very, very nice thing. Um, let's see.
Mm.
Yeah, and just, again, some really great perspectives through here. Um, yeah, and I think the interdisciplinary nature of this can just feel so foreign to so many people because we think about ownership of care, right? Within a consultative model, like the physician tends to retain ownership most of the time. And that could be a hard thing for somebody to wrap their head around. It's like, well, this is my client, this is my patient, right? And
Mhm.
it's like you're part of their care team. Okay. I'll move us to the next question.
Okay.
What are the areas of education and advocacy needed to promote greater integration of the counseling profession in integrated care? Keeping an eye on the chat. I mean, my mind initially goes, it's like grassroots efforts are great. Like
Mhm.
we got to start somewhere, and the systemic change tends to be where maybe increased energy is needed in some respects. What are your thoughts, Tiffany?
Yeah. Yeah, my instant thought is what I was thinking kind of before, one of the barriers that, we're not seeing integrated care in our textbooks. We are seeing it in the CACREP standards, but it's really a kind of this kind of like the slow trickle out, where we really want it to be more more accessible to students. For me, if I hadn't stumbled upon integrated care, probably would not be working in the field, wouldn't be as interested. And so I really think it comes back to our master's level education programs. That's one of my passions, is to see it talked about from the beginning, that this is an avenue, this is an option. This isn't just the exception that a few people go to, but this is hopefully the way that healthcare is heading. This is an advocacy effort on a bigger level. So really to see that integrated into our master's level programs more fluidly. I know there's great training programs out there, but I think it starts in the classroom. It starts planting that seed. So I think that's a big piece.
Mhm. Yeah, absolutely. And I mean, just again, looking through the chat here, definitely the classroom, definitely working with, I guess, CACREP to, whether it be modify the language, maybe start to develop a stronger narrative
Mhm.
around the role of counselors, um, and the abilities of counselors within the setting, can be such a powerful thing. I would imagine too, and I mean, I don't know, I'm halfway across the US now from where I did most of my training at a prior level. I would imagine maybe at the state level is a powerful place to maybe try to intervene, increase advocacy, have an impact on the state level of things. Has there been any of that going on in your area, Tiffany?
Yes, there was another call through CFHA about Georgia specifically. So there is some advocacy efforts there, kind of as I mentioned before, and I'm sure other states have found this, are just our the requirements for reimbursement, things like that, are very much aligned with the specialty model. There's not really this room for same day billing, a same day visit. And so with the sustainability financially, it's going to be important for those to be recognized that yes, a behavioral health provider can see someone on the same day as a medical provider, and that still be a qualifying visit. So those are some of those kind of barriers at the state level that there's continued advocacy for, as well. So it's really asking our state to acknowledge it, really, so that we can work in the clinic without, without barriers and without those access issues, because ultimately what we're trying to promote is access to care, but yet our systems in our state are not quite haven't quite caught up with us yet.
Yeah, yeah, absolutely. Yeah. I mean, and I guess like my mind kind of goes a couple different directions with that too, because yeah, I think, there clearly needs to be some advocacy on multiple levels here, right? And something that my mind's going back to that you had mentioned was exposing counseling trainees early on in the process to this, right? And we're in a tough spot if we don't plant seeds.
Mm. Right, right. And I'm thinking too about I know the CACREP being mentioned in the chat, and yes, we definitely need more representation in CACREP from people who are working in integrated care, people who have that experience and that training. And then I'm also thinking kind of back to the Mental Health Access Improvement Act. There's been so much put out by our American Counseling Association, our NBCC, about you can bill Medicare now. Here's all these trainings that we're going to sponsor. But we didn't hear anything about this addition to the definition of behavioral health providers in our federally qualified health centers and rural health clinics. So I wonder, how can we tap into those advocacy agencies, how we can, again, starting at grassroots and moving that awareness up. And maybe there was something that came out from ACA, or I know I didn't see anything. I really had to dig into the legislation myself and understand it, and then look at CMS. And so those are other ways to see our profession really embrace integrated care.
Yeah, absolutely. And yeah, I'm just kind of looking through a couple of the comments here, and one person had some curiosity around what a routine integrated collaborative visit might look like to a patient, which I think we might all have some varying definitions of what that might look like and probably some similarities. So that might be something we can talk a little bit about. I do want to address David Paul's comment that in order for sites to be more inclusive, I'm not sure a focus on the counseling curriculum will get the medical profession's attention. And
Mm,
it's what if we change the medical field's education curricula to be more inclusive, a team of be
mm,
inclusive and team oriented to patient care.
mm,
And my sense of things is that is happening in some respects with the addition of a requirement of a behavioral health scientist faculty member
mhm,
on physician training programs. Again, it doesn't feel like it's happening fast enough, at
mhm.
least in my sense.
Like there needs to be advocacy in both arenas, both in our behavioral health arena and also in the medical arena as well.
Yeah.
Mhm. Yeah.
So I do know that CFHA is working advocacy wise, at least on that front, to partner with the Society of Teachers in Family Medicine and then some other organizations as well to try to encourage more of that curricula shift and even working to support the inclusion of the behavioral scientist role as a way to introduce medical providers to integrated care and hopefully change the trajectories of medical residents who would not get this kind of exposure otherwise.
Mm, mm, mm. Kind of wonder about that grassroots advocacy now on the medical front too, because I know some of the newer physicians in the clinic I've been in, for instance, they come in and they are ready for integrated care because they've been more exposed to it. And, um, I just wonder what that looks like on the medical front as well. Some of those grassroots efforts to, tell your colleagues and tell those that you can about integrated care if those things are not in place in the universities or in the training programs. Um, it's kind of advocacy on all levels at this point.
Yeah, absolutely. Well, and I'm wondering too, I mean, Tiffany, given like your experience, your setting as well, one of the things that I have seen that can be helpful is simple things like a lunch and learn, small workshops, even little things like informational handouts, small ways of just helping people learn and buy into the service, start using, and then like, oh wow, this actually does make a difference.
Mm-hmm. Hmm. Yeah, absolutely. Even in our regular clinic flow, we find ourselves having to do that too, having to kind of recalibrate sometimes. We might go a few days and see that we're not getting um, those patients with weight management challenges. And hey, reminder, I can help with that too. Kind of those continual efforts are so important.
Absolutely. Absolutely. Yeah, I'm definitely curious and maybe this is something to we'll think about as well as in the future, like strategies for advocacy as well. I think that'd be an interesting conversation too. Okay. Well, why don't okay. So I think that was the three topics we had. So that being said, I'd love to kind of just turn the floor over. I'm keeping an eye on the chat here, burning questions, lingering thoughts. I know one of the things that had been requested was maybe a breakdown of what the format of a visit might look like. So Tiffany, is there anything you'd like to kind of chime in, start with, and I'll keep an eye on the chat for a minute?
Sure, sure. So an integrated collaborative visit. So I'm assuming some folks in here might be really new to integrated care, and it's kind of hard to envision. I think when you think about going to your own doctor's office, what would that look like for a counselor to show up in my clinic if I've not had that experience before? But we really depend on a lot what we call a warm handoff, and a warm handoff is kind of exactly what it sounds like. The physician is maybe in a room with someone, maybe they see something in a chart and they say, hey, Tiffany, I've got so and so coming in. Could you go ahead and get started with them when they come? They were here last time for I work in pediatrics right now. A common thing that comes up is stomach aches or fatigue and anxiety. Could you check in and see how they're doing since we last talked? You and I saw them last time. Or if it's a new person, they might say, I really suspect this person is having a lot of stress. We serve a lot of immigrant population as well. And so there's a lot of stress. There's a lot of post-migration stress here. Could you talk with the family? I think that might be a part of what's going on with these headaches or these stomach aches. And so then I would walk in the room, begin with an introduction so that they know who I am. Now, because I'm a counselor, I often say something like, I'm not a regular counselor, what you think of as a
Mm.
regular counselor. I'm not going to be in here for an hour. I kind of start off with that because there's kind of this idea that that's what counselors do. They meet with you for an hour. I let them know I'm here just like your doctor to visit. I am here to help with anything that's going on today. Just a really quick introduction, and we might be in here for 15-ish minutes, and then we'll come up with a plan and see how you feel, and we'll decide if you need a follow-up. And then that kind of sets the stage for that kind of ideal, warm handoff. And we use those same skills. We are still counseling. We are still finding out what is going on with these headaches? How are you feeling stressed? Are you in school? If I'm working with kids, we're still doing that interview. In integrated care, we often call it a contextual interview. We want to get to what is really contributing to this issue and then try to come up with a plan. So it's not vastly different than what you would think of as a counseling session that would last 50 minutes. It's probably a more condensed and kind of gets more kind of to the issue, maybe kind of more aligned with what we think of as maybe solution focused, if that's a term that's more familiar. So yeah, but feel free to add to that.
Yeah. I mean, I think you such a great description. And yeah, my sense of things is talking with people, whether you're in counseling, social work, marriage and family therapy, whether you're working as a psychologist within these settings, collectively, we do a lot of the same things.
Mhm.
And, really one of the biggest things that was emphasized to me early on is this is primary care, right? And so we want to shape and format what we do to be consistent with the pacing of primary care.
Mhm.
So definitely the format you're describing to a T, very much what I do as well. One of the things that I do, and you might have mentioned this as well, is I try to close the loop at some point with that physician at some point in the day.
Yeah.
Because for my underutilizers, I try to reinforce their engagement in our services. And then for our high frequency folks who refer a lot of people to us, that can also serve as a point of education, encouragement, reinforcement, just further promoting the services. Because one of the things I can say is if, let's say, we are in this kind of setting and it runs 50 minutes, physicians notice that, medical staff notice that. And if it doesn't feel like we can operate within that pacing, they're going to be less likely to use our services.
Mhm. Mhm. Yeah. That's a great point, that closing the loop. It's kind of like where the magic happens. That's where you're influencing the visit. You have that opportunity, well, it was actually this that we talked about. And it could be something very different than what the physician was looking at. And they have an opportunity to educate you too.
Mhm.
Sometimes I come out with questions and I'm asking, what's this term that I saw I'm not familiar with? And that that like cross pollination
Yeah,
between our disciplines. Yeah.
absolutely. Yeah, I mean, and like what a wonderful partnership to have, right? Like on so many levels. Casey, I saw you posted a comment just wondering thoughts on balancing co-located and integrated care in a clinic. That is an interesting one.
Yeah. That
Does
is
does
that's a
Go ahead.
tough one. That's a tough one. Because I'm in a fully integrated clinic, I am just integrated all the way. I don't have an office, and I I sit right beside the physicians at the workstations. We're dialoguing throughout the day. And now that I see the benefit of that, it's hard for me to shift back to a co-located. I think that's hard to manage because I think you've got two different almost like kind of two different schools of thoughts about behavioral health care happening in the same setting. And it can it can be difficult to, I think, clarify roles. So if you're, especially if you're doing both, and I don't know, Casey, if clinicians are doing both.
We're
It's like,
doing both.
what was that?
We do both.
Okay, so as one clinician, you do both. It's kind of like, I can almost imagine that you would have to kind of like have a certain hat on to say, I'm in integrated mode right now and I'm in the clinic. And then for this part of the day, I'm over here doing co-located. I think it would be hard to manage, but it's one of those things that I think comes up a lot because we have a lot of clinics that are co-located. They're moving toward integration, and that's still a movement toward integration. I think we want to celebrate that, but I think that is a hard hat to wear. I did that at one point, and it was tough. It was tough to maintain. I definitely liked being able to work in one or the other, or at least be able to portion out my day where I knew if there was one part of the day I was doing more co-located, and then one part of the day I was doing more full integration. I hope that helps some.
Hey, Danielle, I see you have your hand up.
Yes, I have a question about those visits, those brief visits that you have. Those are being billed, right? I mean, you're meeting with them and billing them?
Mhm.
That's right. Okay. So I am co-located at my clinic. So I'm seeing visits, I'm scheduled. My day is like packed, every like 30 minutes I'm seeing somebody. We did try bringing in a student once a couple of years ago, and it worked out, I mean, fantastically, as far as like we got great response from the providers and all that. However, it didn't work out at the end. We didn't renew the contract. That's beyond my, of course, my say. However, how do they make that change from saying, okay, Daniela, you're going to be doing, you're going to be in the hub with all the providers, and we can't guarantee that you're going to see 12 to 14 people a day. How does that end up working out? Like, I wouldn't know how to convince my administration to say, hey, that's probably the best thing overall as far as like quality of care. It's kind of like the long game. Right now, I don't see them putting me out on the floor when they can pack my schedule, you know? So I guess I'm wondering, like, how does a place like the one I'm currently working at shift into integrated care and not consider money over whatever? That's a big question. I guess I just laid on you. I'm sorry about that. It's just that's what I think of, because and we work remotely for the most part, which has worked out for our patients, but now we're slowly getting back into the clinic, and I still feel like there's this huge separation between myself and the provider still. you know and I agree with what Corey said. I know it is moving forward, but not as fast as we'd like, or it certainly doesn't seem that way. And I just wonder, how that works. Like, have you experienced that a clinic goes from being co-located to saying, hey, we're making this decision? Like, how does that even get done?
I mean, I'll chime in at least a little bit to this, and Tiffany, I'd love to hear your sense of things. I mean, realistically, there's a lot of people that make big decisions that don't necessarily always have a direct role in patient care. And so, that disconnect there can be a really influential factor. And a big part of it is financial, right? And demonstrating cost benefit savings, profit, all those sort of things play such a huge role for so many, which again, at the end of the day, that's such a hard point to see. My limited experience with it is that I've worked and collaborated with other professionals where they try to start some informal advocacy efforts within their organizations to demonstrate cost savings, especially for folks that are high utilizers of the ED, for example, folks that are also very high utilizers of primary care services to the point where they're accounting for a significant number of visits, and usually there is a behavioral component attached to that in some way. I think one of the tricky parts you're describing, Danielle, as well, is it's hard when we're working remotely. I'm not going to pretend it isn't. Like it's hard. because we're not necessarily in the trenches at the same time having as much visibility as we might like. I don't know. So like the first area that maybe my mind goes in this particular case is like, how do we demonstrate the value in this to somebody who may not understand that? And that might be some advocacy. It might be figuring out who do I speak with to help them understand it's like, this is kind of what we do. This is the cost savings from these things. Because at the end of the day, that speaks loudly for medical systems is money. I mean, it is a big role.
Mhm. Yeah. 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 I feel like that's the area of advocacy I'm not good at when we start talking about the money. It's hard for me to conceptualize. I know it's important, but in my humanist perspective kind of takes over and is like, but the value of the care and what our patients are getting. And if we can demonstrate that, and if we can kind of meet somewhere and quantify that, I think that helps to tell the story, at least putting a story to the numbers, to help those who might not be in that direct care, like Corey said. I'm in a clinic that I'm really fortunate that they're really committed to integrated, and but I've known clinics that have gone back to co-located because of some of what you're saying. And I know here, we've received consultation through CFHA. We have kind of really tapped into CFHA as a space to help us to continue to advocate for, really ingraining in our leadership that integrated care is the way. It is the way to go. But also, there are certain grants sometimes that can help depending on the agency as well. If there's some sort of transition or training. I know I'm not as well versed in that, but I know that sometimes that is a possibility to help at least temporarily if there are concerns about shifts in funding and things like that.
Thank you for your response. Appreciate that.
Absolutely.
Absolutely. And Tiffany, I appreciate your CFHA plug in there too.
Yeah.
We do, Daniela, we do have some wonderful people within our organization who have fought some of the same battles that you are fighting and then some. I would say like, please, 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 like reach out to us and we'll try to get you connected with somebody to try to help with that effort too. Because again, it takes a village, right? And I hear you and I hear the passion in your voice, and I can only imagine how hard it is for you to see this shift when you've seen such good, from what you were doing within this integrated care capacity. So we have about 4 minutes left. That being said, we've had a couple questions about the co-located care aspect of it, and that might be a good point for us to kind of wrap up on for today. And yeah, talk about ambiguity, right? Like, well, how are you different from this person? That sort of thing. Tiffany, do you have any kind of co-located care as part of your system you're at?
We don't now, and previously, a few years ago, we tried to do that a bit, and it was, I think somebody was asking in the chat, do you like refer them to the co-located person? And that is what we tried to do. The person would see the person for a warm handoff and then would say, you can, see, and it was me, they were seeing me for co-located. You can see Tiffany for, kind of regular therapy. And so that's how that worked for the time, but it didn't sustain. It was difficult because of the differing roles. It was difficult to explain that, and it was then difficult to kind of figure out how we would maintain that when we could also refer people to more traditional counseling services. So it became a little messy, and for us, for that reason, we just really stayed within the integrated model. And I saw somebody mention like the COCM. We've tried that too, and that gets again, the roles. I think clarifying roles and when you're in those roles can be really helpful when you're trying to mix two different models. But again, the clinic I've been in, we've always gravitated back to we're just going to focus on PCBH and do really good integrated care.
Mhm. Yeah, and I think at least, so Tiffany, I appreciate what you're saying, and as someone yourself who has like tried doing both of these, I gotta imagine the switching back and forth of hats, and same for several of the other people on here, can be a challenge.
Mhm. Absolutely. I think that's definitely the biggest challenge, especially if you're the same person providing both.
Mhm.
I think it could, certainly maybe it could be different if you have set people providing different types of care. But because then patients run into you and they want to see you for this, and yeah, it just gets a little tangled.
Yeah,
Yeah.
absolutely. Yeah, and I know that, just to give another plug for our organization, CFHA does have some wonderful conversations around COCM. And,
Mhm.
people have different perspectives on COCM, on, whether you're someone that does prescribe, whether you're specifically someone that works on like the behavioral health kind of perspective, humanistic perspective. One thing I can say is our organization has a nice balance of views on that.
Mhm.
So that can be an avenue as well if you have more questions around COCM. And the last thing I'll say is it's very state specific too.
Yes.
So that's another situation as well, as your state might be a state where there's been a lot of advocacy for more COCM, and then you might be in a state where that's not quite the case. So that does play a role in terms of that situation as well.
Mhm. Mhm.
Okay. Well, we're about at the top of the hour. So, first off, thank you all so much for being here today, joining us for this community conversation. Tiffany, thank you so much for your unique insights, the impact that you're working to have within the counseling field. And, thank you all for just your valuable contributions. My sense of things is we probably will have another conversation at some point in the future
Mhm.
around these topics again.
Great. Yeah. Thank you all so much.
Thank you, everyone. Have a great week.